Hello everyone, this is Assistant Professor Ali Abdul Karim from Department of Periodontics, College of Dentistry, University of Baghdad. Today's lecture is evidence-based relation between periodontal disease and excessive occlusal force. First of all, we will start with some definitions. Excessive occlusal force is the force that exceeds the reparative capacity of the periodontal attachment apparatus, which results in occlusal trauma and/or cause excessive tooth loss. While occlusal trauma is defined as injury resulting in tissue changes within the attachment apparatus, including periodontal ligament, supporting alveolar bone, and cementum, as a result of occlusal force. The primitus is a visible movement of the tooth when subjected to occlusal forces, while praxism or tooth grinding is a habit of grinding, clenching, or clamping the teeth. Menkerias cervical lesions is the loss of the hard tissues at the cervical third of the crown and subjacent root surface. Refraction is a hypothetical tooth surface lesion caused by occlusal force. It is defined as a wedge-shaped defect that occur at the cement-to-enamel junction of affected teeth as a result of a fracture and eventual fatigue of enamel and dentine. In a clinical setting, it is hard to diagnose occlusal trauma, therefore multiple clinical and radiographic indicators are used to achieve this diagnosis, as shown in this table. Effects of occlusal trauma on the initiation and the progression of periodontitis. Before proceeding in this topic, we need to understand what primary and secondary trauma from occlusion mean. Trauma from occlusion can be initiated when the intensity of forces exceeds the adaptive threshold of periodontal supporting tissue. This is called primary trauma from occlusion, and it is associated with intact periodontium. Or when the tissue adaptive threshold is weakened to the point that the remaining supporting tissues are unable to withstand the physiologic occlusal forces, and this is called secondary trauma from occlusion. Trauma from occlusion produced by jiggling force, which is characterized by widening of the socket at the cervical area and apical area on other occasions. This results in development of funnel-shaped bone defect with no distinction between pressure and tension sites, which means that both can occur at the same place alternatively by a back and forth mechanism. On the pressure side, there is increased vascularization and permeability, increased hyalinization and necrosis of PDL, increased hemorrhage, thrombosis, bone resorption, root resorption, and cemental tear. While on the tension side, there is elongation of the PDL fibers, apposition of alveolar bone, and cementum. Overall, trauma from occlusion results in decreased density of the alveolar bone, increased width of the PDL space, increased tooth mobility, radiographic evidence of widening of PDL space, and primitus. In the early 20th century, early investigators suggested that excessive occlusal force is the cause of periodontitis. Later, in 30s and 40s, studies on human autopsy materials concluded that gingival inflammation extending into the supporting bone was the cause of periodontal destruction. Later, results from animal studies showed that excessive occlusal force caused changes in the direction of the periodontal membrane fibers, so that gingival inflammation passed directly into such area. This combined effects of occlusal trauma and bacterial plaque-induced inflammation was termed as co-destruction. In general, These historic studies failed to establish any causal relationship between trauma from occlusion and the initiation and progression of periodontal disease. In an attempt to prove a relationship between occlusion and periodontal disease, multiple animal studies with strict controls and design were performed in the 1970s. Among these, there were two significant groups, one from Eastman Dental Center in Rochester, New York, and the other one from the University of Gothenburg in Sweden. The effect of occlusal trauma and gingival inflammation in animals were investigated by the two groups. For the Eastman group, they used repeated application of orthodontic-like forces on the teeth of squirrel monkeys, while Gothenburg group used occlusal forces similar to those of a high restoration in beagle dogs. Both groups examined the effect of excessive occlusal forces on the periodontium with a duration from a few weeks up to 6 months in the presence or absence of bacterial plaque-induced periodontitis. Despite using two different models and designs, both groups reached the same conclusion, which is without plaque-induced inflammation, occlusal trauma is not a causative agent of periodontitis. In another experimental animal study, rat model was used. Occlusal trauma was induced by either placing inlay or metal wire bonding to raise the occlusal surfaces. The outcomes of this study showed destruction of the PDL and increased expression of rankle with LPS-induced inflammation. This study concluded that the loss of connective tissue attachment is increased when combined with trauma from occlusion. Also, bone loss increased with estrogen deficiency, nicotine, and diabetes when combined with trauma from occlusion. Although interesting results were obtained from animal studies, however, none of these models were able to reproduce all aspects of human periodontitis. Excessive force and relatively short duration were applied during these experiments. Also, animal dentitions and motion of the jaws are different from that of human. But in conclusion, we can say trauma from occlusion does not cause periodontitis, but it may be a cofactor that can accelerate the periodontal breakdown in the presence of periodontitis. For clinical studies, we will start with demonstrating results from selected observational studies. The first study, it was an epidemiological study in which a group of subjects were re-examined for loss of periodontal clinical attachment over 28 years. Results showed that mobile teeth were associated with greater broken depth, more clinical attachment loss, increased alveolar bone loss, and unfavorable outcome of periodontal therapy. In conclusion, it was found that baseline tooth mobility was a factor related to clinical attachment loss. Another retrospective study investigated the relationship between periodontal clinical parameters and molar non-working contacts. The results showed that molar teeth with non-working contacts had a greater dropping pocket depth and bone loss. However, other studies failed to find any correlation between abnormal occlusal contacts and periodontal clinical parameters. Conclusion of these observational studies can be summarized by elimination of the trauma from occlusion could improve the clinical periodontal condition. The evidence linking occlusal adjustment to improvement of periodontal parameters is limited. A series of clinical trials were conducted to investigate the effect of occlusal adjustment and outcomes of periodontal therapy. In the first study, there was a gain of a clinical attachment level which was equal to 0.4 millimeter. In the second study, there was a reduction in the propping pocket depth which was equal to 0.1 millimeter per year. These changes were clinically insignificant. So in conclusion, plaque-induced inflammation cannot be treated by occlusal adjustment, and occlusal adjustment may improve the prognosis of periodontal therapy. Trauma from occlusion and gingival recision. Historic references suggested a relation between trauma from occlusion and gingival recision. However, these historic references are based on uncontrolled clinical observations. Evidence from more recent studies suggested that there is no correlation between mobility and gingival recision, no relationship between the presence of occlusal discrepancies and width of the gingival tissue before or after periodontal treatment. In conclusion, existing data do not provide any solid evidence to support the effect of occlusal force on gingival recision. Effects of orthodontic forces on the periodontium. Clinical studies have demonstrated that with a good plaque control, teeth with a reduced but healthy periodontium can undergo successful tooth movement. An uncontrolled orthodontic force can negatively affect the periodontium, resulting in root resorption, pulpal disorder, and alveolar bone resorption. The long-term effects of orthodontic forces on the periodontium have been controversial. A recent systematic review has demonstrated that orthodontic therapy was associated with 0.03 mm of gingival recision, 0.13 mm of alveolar bone loss, and 0.23 mm of increase of propping pocket depth. Overall, the existing evidence suggested that orthodontic treatment has minimal effects on the periodontium. In summary, available evidence suggests that trauma from occlusion is positively associated with the progression of periodontal disease. But excessive occlusal forces do not initiate plaque-induced periodontal disease or loss of periodontal attachment. Trauma from occlusion do not cause abstraction or gingival recision. Thank you for your listening.